Welcome back to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes with your host, Dr. Rhiannon Winsor. Dr. Winsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she's spent her career helping clinicians and care teams optimize patient outcomes. On today's episode, we dive deep into what it really takes to make telehealth work beyond the pandemic. Dr. Winsor is joined by health technology expert Christian Milaster for a practical, behind-the-scenes look at how workflows, clinician training, patient experience, and change management all come together to create successful virtual care. From virtual rooming and onboarding to clinician confidence and reimbursement challenges, this conversation goes far beyond the basics to explore how telehealth can truly improve access, continuity, and quality of care. If your organization is looking to move telehealth from a stopgap solution to a fully integrated care model, this is a must listen.
We've had a few of these conversations already, and we've covered a lot about the value and the potential of telehealth. And I was thinking we can focus on what it really takes to make telehealth success. My first question has to do with workflows. And this is a hard thing to change for health centers. So this new thing that's coming in is disrupting these workflows that I'm sure that they've perfected. What are some common mistakes that you see regarding, just kind of taking this new thing and trying to fit it on? Like, how do they really integrate this into their workflow?
Very good question. And yes, the workflows are definitely at the core of what this is really about, which is change management. It's getting people to do things in different ways as they've always done it. I actually want to challenge you on that premise in that they have really well-defined workflows that are optimized and that are perfected. Now, every clinician has on their own developed their own perfect workflow that works for them, and all the nurses and the medical assistants know that. And they said, oh yeah, for Dr. Miller, we need to do it this way. For Dr. Stevens, we need to go this way, right? And so everybody's has been permitted to develop their little idiosyncrasies, which again, healthcare is highly individualized. Every patient is different and you need to adjust it to your style. Every physician has a different personality and they need to lean into their personality to be an effective clinician. And from that, derives itself that you also maybe have different workflows. You want certain information at different times than other people, and we need to accommodate that. We're not on a factory floor where we're saying next, next, next. Maybe you can do that with dental cleaning, but even there, the teeth are different. But when it comes to primary care, when it comes to behavioral health care, when it comes even to dentistry, beyond the cleaning, we need to allow clinicians to provide their individual services and to their individual preferences. And so, but you're right. I mean, telehealth was being seen initially. Many FQHCs did not start before the pandemic as just a bolt-on, right? It's just, okay, here's a webcam and a Zoom license, go and do telehealth. That didn't work, so we were just doing telephonic telehealth, which in my opinion, I'm not a clinician, it just doesn't have the same clinical efficacy. You don't see the facial expressions, you don't see the patient surrounding, you don't see the demeanor, you don't see when they're tilting the head because they're not understanding, you don't see them looking up because they're processing what you're saying, right? So you cannot really gauge your communication, and so much in our 7 or 12 minutes that we have with the patients is about the communication to listen to what they're saying, but also to convey to them our expertise or the clinical expertise to guide them in their management of their care. And so really nobody really had thought through what it would take to actually create a PERB telehealth experience, because in March 20th, 2020, everybody was just in a panic mode and said, we got to see our patients, we got to connect with them, we got to get their medications refilled, we got to address their heart palpitations, we got to see if we need to send them to the ER or not, we got to see, do they have COVID, do they need to be admitted or not, right? We were in crisis mode and we were doing triage. But now that telehealth has become a standard care delivery method, we really need to think more strategically and more systematically, rather, about the workflows. And so let me just recreate what actually is inpatient visit look like. What are the different workflows that are involved? And again, that's where I, as an engineer, like being new to healthcare, I mean, for 25 years yet, but that's how I look at the world, right? I look at through the worlds of workflows and processes. And the first one is there's a scheduling process, right? The patient needs to be connected with, or the patient connects with the clinic and sets up the appointment, either while they're in a clinic after the last visit, or when they call the clinic, or when the clinic calls the patient. So that's the first step. Then they present in the clinic, they check in, and then there's a rooming process, right? They get led onto the scale, they get led on to the blood pressure cuff, and then the nurse positions them typically in the medical exam room and then informs the clinician that the patient is ready. And then the clinician reviews the clinical chart and then knocks on the door, enters, and said, "How are you doing today?" Then they go over the visit, and then afterwards, right, the patient just doesn't dart out the door into the car and out off they go. No, right, there's a process. Sometimes the nurse comes back in, talks about a few more things. Sometimes you stop by on the exit to schedule your next appointment, to get referral documentation, or just to clarify anything that is still needed, and then you leave. And then then there may be follow-up. Sometimes they give you a note, sometimes note appears in your patient portal, so there's a follow-up. And then ultimately there's a billing component behind the scenes, right? So those are the kind of 6 common steps of an inpatient workflow. And then if you are a new patient, then there's an onboarding or registration process, right? You need to fill out a lot of forms. You need to, right, establish all those relationships. And so those are the 7 workflows. And so what we did in the wake of COVID, when it really hit home, we needed to redesign each of those 7 workflows for the telehealth environment. And how is scheduling different? Well, you got to be in a place where you have Wi-Fi and you need to have the technology. And actually, it needs to be clinically appropriate that we schedule you for telehealth. The rooming process, that is the one that was mostly overlooked. People clicked on a link, they were in the waiting room, ideally in a video, and then the clinician joined at some point in time. Nobody was taking your vitals, nobody was taking your chief complaint. Right, it's just jumped right into just having the virtual visit. There was no virtual rooming process. Some clinics later on developed some phone protocols that were a little bit awkward. The best of our clients are now using the client joins the video waiting room, gets picked up by the nurse. They have this revisit process, then puts them back in the waiting room, and then the clinician joins and enters them. So we have recreated now in a virtual environment with the right technology an experience that is very much like to the proven, well-established, well-honed in-person experience as well. And then the onboarding, that is really the part that also was missed, is when a patient is doing a telehealth visit for the first time, right, and which is akin to being a new patient, established patient, knowing how to get to the clinic and filling out all the forms. We instituted a telehealth tech check. So a patient doing for the first time a visit, just really jumping into with a patient a few days before and saying, "Hey, Rhiannon, you have a meeting scheduled here with Dr. Miller here on Thursday. I see this is your first time using telehealth. Have you used FaceTime before? Do you have a few minutes and I can just walk you through what to expect?" So, "Yeah, okay. Is this your phone number? Yeah, okay. Let me send you a text. Did you get the text? Yeah, why don't you click on it? Okay, you see you in the waiting room. I see you. Okay, let's switch over to video and say, oh, okay, I see, yeah, okay, your background looks really great. Your lighting looks great. Just make sure that you look into the camera so the clinician can see you. Don't put the phone down, prop it up." All right. So again, these little 7-8 minute tips and tricks to really onboard the patient so that the clinician and the patient could just focus on the visit and the technology faded in the background because it was all set up. So long-winded answer, but really a deep dive into the workflows, right? Telehealth or telescheduling, tele-onboarding, tele-rooming, televisit. That is the most straightforward of all. And then tele-post-visit, tele-follow-up, and tele-reimbursement, right? Those are the 7 workflows that need to be defined.
Yes, and what's really coming through for me is we can't think of inpatient visits and telehealth visits as the same thing. Like there really is the components, what we're doing for the patient is similar, but how we're doing it is very different. And so that takes like a different mindset, a different way of thinking about things and how, that's all going to fit together. And are there other things that you can think of that can help the clinician and the patient be more comfortable as they're engaging in this whole telehealth thing?
The first thing that clinicians really want to understand is the why. It's becoming of lesser criticality as it was in the years after COVID, but clinicians wanted to understand why are we still pushing telehealth, why we're still doing video visits, because again, it was seen in the initial years by most as a stopgap measure to just being able to still access our patients' care. And now we understand it is actually improving access to care for the patients who have difficulty of transportation, difficulty of making time. You have to take 1.5 hours for a 12-minute visit, right, with a clinician. You have to build in that time. And that time, some people have 2 jobs, some people have little children and cannot arrange or cannot pay for childcare. So there's all these barriers, especially in rural, but also in urban areas where the patients, especially the population that most FQHCs are serving, where they just don't have that luxury of just taking 2 hours out of the day to see their clinician. Right. And so whereas a 15-minute telehealth visit in the parking lot of your employer is absolutely doable, right? I can take a smoke break, so to speak, and don't smoke. It's bad for you, but right, I can take a break. I can tell my supervisor I have a medical appointment, right? I'll be gone for 20 minutes. But not for 2 hours because this is telehealth, right? And so they'll be thrilled. So that is all doable. So the clinicians need to understand the rationale for it. Also, again, we need to acknowledge that telehealth is as an outlier there in all the telehealth reimbursement. Telehealth is not reimbursed at the same rate as an in-person visit. All other many states have payment parity laws in place for telehealth, where commercial insurers are required to pay the same amount of money for an in-person visit for a telehealth visit as they would do for an in-person visit. But again, with the FQHC and the PPS rate, we are getting paid much less. It's around $96 this year for a telehealth visit. On the other hand, it's $96 is still more than $0 if the patient is not coming in at all. Right. And so, again, if you have 100% full schedule, then you don't worry about having telehealth visit. But if you have scheduling holes and you fit in telehealth visit, then at least we're getting kind of at least 60% or hopefully 40 to 60%, again, depending on a PPS rate. You're still getting something at least. And hopefully that weird thing will be removed at some point, because all the evidence points to that a telehealth visit is just as efficacious and effective as an in-person visit, and sometimes even more so because of the continuity of care, avoiding an ER utilization. So in a value-based care environment now, if we're switching on that, then we don't have to worry about if it's not fee-for-service. Then we can do whatever is right, and we can have 7 telehealth visits and 1 in-person visit if that is what helps the patient to stay out of the ER, to recover from their discharge and to not be readmitted, and to manage their chronic disease as well through continued conversation, right? And so really, again, we're straddling these worlds and have been for 10 years or more of value-based care and fee-for-service, but we got to design for both scenarios. So that's the first thing. Clinicians need to understand why is telehealth there. And then a lot of them ask rightfully, and sometimes also as a red herring, is like, well, where's the clinical, where's the research that shows that this works and this is good? And there's research out there. And so there's definitely evidence for that. All major health systems are doing telehealth, 10, 20, 30%. The specialty visits, sometimes even upwards of that. So everybody's already doing it, and the academic medical center wouldn't be doing it if it was bad medicine. And so you cannot just hide behind that any longer, because it has been proven. But a lot of it is hesitancy, right? It's feeling uncomfortable. Clinicians, from my perspective, what I've learned, have been trained to be very confident and assertive, and they have to be, because when the patient says, "What's wrong with me, doctor?" and say, "Well, I don't really know. Let me just let me look up my Medscape research here. Let me see what I can find for you. So I'm sure we figure it out." Well, no, that's not what you say to the patient, right? You say, right, okay, well, we'll get your lab test and I'll call it, right? And so you assert the confidence. if you're using your personal language, if you're in an in-person meeting, right, you can lean into the patient, you can reach out to them, you can engage with them, you can react with them. That all is taken away when you're in a video visit, especially if the iPhone is laying on the dinner table pointing at the ceiling and you're trying to establish a connection with a patient that is somewhere talking in the off-camera world, right? That is not the same as an in-person visit. And so rightfully, clinicians were feeling like a fish out of water. And my starting point is always that everybody had post-traumatic stress disorder from telehealth during COVID. That's my basic assumption. And then that's my compassionate understanding to start from. And then a lot of clinicians have had good experiences. So it's not true across the board. But I always start with that first impression experience. And that for many people, it was disorienting, to say the least. So the next part is really to build up the confidence in clinicians that they can practice really good medicine over video. There's two aspects to that. One is what we call jokingly webside manners, right? So the bedside manners adopted for the web, right? What do you need to do? You need to look into the camera. You can lean in, you can use your hand gestures, and you can just really use the camera. You can explain like what's on the background there, what's hanging on the wall, or you can explain when you're looking to the right, you're looking at the EHR to making some notes in the medical record, right? So you can explain yourself. And again, we do this website manners training in 20 minutes, and it makes a difference of a 4.3 on a 5-point scale and a 2.7 on a 5-point scale. That is data that are collected in an FQHC in 2020 in the wake of COVID. It makes a whole lot of difference to just build that confidence. The second part, especially in primary care, is the lack of the exam capabilities, or the perceived lack of the ability to perform a physical exam. Now, first of all, what I have learned from clinicians that many clinicians don't use the physical exam to diagnose. They use it to confirm a hunch, and they will send patients still off to a radiological testing or lab testing, but still they do the exam. And and sometimes you may find something that is surprising or unexpected, but typically from the history of the patient, from the symptom description, from the medical history, and you kind of know, I mean, within a minute, most clinicians have told me what's going on. You have a hunch and you just confirm it through questioning. And then you confirm it with other lab tests, right? And so, again, we don't necessarily need virtual exams, although they can be very helpful. And so what we are doing, we're also then doing a kind of 30-40-minute one-on-one clinician virtual physical exam training. So we are having our chief clinical officer, who's an internist from the Cleveland Clinic formerly, who's done telehealth for 20 years and established their urgent care, the virtual urgent care program. He's sitting down with the clinicians of our clients, and he's going through the virtual exam training. They're really telling them, okay, have the patient tap their sinuses and see that, right? Have them palpitate, have them describe what does it feel like? Does it feel like a hazelnut, or does it feel is a lump heart, right? Anything that you learned in medical school on how to do this exam, you can walk the patient through, and then you noted in the medical record that it was a patient self-exam that you facilitated, so that the next clinician who looks at your notes knows how to put that particular assessment in the context of knowing it was just a guided virtual exam. But that's an enormous thing. We can assess gait, we can assess range of motion, right? We can have the patient stand up, go back. Obviously, most people can't hold up the foot to show their ankle, so we have to be creative, especially with a smartphone. That is usually possible. But to see swelling on the ankles or something like that, right? Again, you just got to be creative. You just got to think a little bit outside the box. But it's amazing how many of the systems you can actually assess. And by just our Dr. Feynman just walking clinicians through it, that totally now changes their confidence in being able to still practice really good medicine. We need to have really great workflows so that when the patient shows up, they're ready, they're prepared, just like in an in-person visit, right? We need to have technology that is very user-friendly, not just for the clinician, right? Clinicians love it. Oh, I can be in the medical chart, I click on the link and I'm in the video. The patient, on the other hand, had to find their login password to the patient portal, reactivate their email account because they lost their password because they don't use email anymore. They only use texting and Facebook. Then they had to log into the patient portal, overwhelmed by the 17 options that are there, until they finally noticed the little blinking orange box that says you have a telehealth visit coming up. Then they go through 3 screens, filling out all the information if anything has changed, because nobody's talking to us anymore. It's all just electronic. And so by the time they get there, the patient is flustered and it's like, okay, my camera, I think, is working, my microphone's working, right? And so the physician says, oh, it's so great. Anyway, I'm exaggerating a little bit, but not really. A lot of the video solutions that are built into the EHR are optimized for the clinicians, not for the patient experience. And because those developers did not sit down with patients, from my perspective, or when what I see, to really design their user experience requirements. Other solutions that we've selected for our clients, you just click on the link, you go to a web page that says, right, Dr. Rhiannon, and at this clinic. You select the provider you want to see, or it's even pre-filled, and you click enter, and then you're in a waiting room. That's it. One link, always the same link, every visit, and you just go in and you're in a waiting room, and that is all that the patient has to do. Now, and then a nurse interviews them, or they may direct them then to a questionnaire, right? If we have a PHQ-9, it would be great to actually have the patient fill it out in real time there, right? We don't have to do this, and then we don't have to transcribe it. So we need to have some efficiency of scale. But again, healthcare is personal, and it should start and end with a personal interaction. So that in combination is how to address the hesitancy of clinicians to really understand it as a hesitancy to not look stupid, right? Nobody likes to look stupid, and especially not clinicians don't like to look unprepared or unprofessional. And then if something goes wrong, we need to have telehealth support. If something's not working, right, they try it 2 times, and then they have a number to call, and somebody can walk them through how to fix the problem, or there's an immediate workaround so that doesn't disrupt the experience. But with good technology and good workflows, those support requests are really few and far between, especially with the training. So that's kind of on the clinician side, and then we can talk next about the patient.
I think that's all such good information, really great takeaways. I always say we need to start with the WIFM. Anytime we're talking to anyone, is like, what's in it for me? That's the whole premise behind adult learning. And, it's like, why do I have to be learning this, doing this? And at the end of the day, I would think that all clinicians, they do this because they care for people and they want to care for patients in the best way. And if we can show them that telehealth is one way to do that, then I think that's just one step closer to bringing them over to the other side, But
right.
I can kind of relate to the whole telehealth during COVID, because I was managing a fully residential on-ground program at a school, and we had to get online overnight, and the students were mad, and the faculty were mad, and we didn't know what we were doing. We were just scrambling to try to at least keep some sort of connection with our students. So preparing the clinicians and preparing the patients.
We're looking at 5 levels of training for clinicians. And the first one is just this awareness training. What's in it for me? Why is this important to the organization, for me, for our patients? That's 10 minutes, right, in a group setting. Then about the workflows. Here's what's happening beforehand. Here's what's happening. Again, the clinicians shouldn't have to worry, just like in an in-person visit. There's no workflow, but the patient is you are going into the room and the patient is there. And that's what we're recreating. But they need to have awareness with regards to what's happening with scheduling, post and pre and post, so that they know and can anticipate what the patient is going to go through. Or they say, okay, when I sign off here, you're going to be talking to Nancy again next here, right, that you saw during the intake. So they can create for the patient the experience. That's another 10 minutes. Then the technology, again, which should be really simple. How do I know it's a telehealth visit? And then when I have a telehealth visit, how do I know where to go? And then how do I use the waiting room? How do I share my screen? How do I send a text message, or how do I send in a PDF? Maybe, right, for some patients, you might not do that. So that, again, is another 10 minutes, because these technologies are not that complicated. Then the website manners training, again, can be done as a group training. That's 20 minutes. And then we opted, based on the guidance of our Chief Clinical Officer, Dr. Feynman, to do the virtual exam training 1-on-1 or 2-on-1, just in a small environment, so the clinicians can really just and feel comfortable to ask questions without the kind of peer pressure there. So that's 30, 50, 60. That's 1 hour and 20 minutes of total training. and it'll make a total difference with regards to how clinicians are doing on. Now, this only works if the patients that are scheduled for telehealth are the right patients. And I always like to say that 100% telehealth is not a dream. And what I mean by that is it's not 100% of all outpatient visits should be telehealth, but 100% of the visits where the patient wants it, where the patient has the technical capability, and where it's clinically appropriate, we should be delivering 100% telehealth all the time. And that is really, and so, but it's the clinical guidance that needs to be then developed next. Now, if you're scheduling a follow-up visit, you as a clinician can make a decision on whether telehealth is recommended or not. So that's easy. But if somebody's calling in and said, yeah, I have these symptoms, I need to be seen, right? We are developing together with the clinicians and then training the schedulers staff on kind of the clinical guidelines or clinical guidance rather as to what are some appropriate symptoms. Where do we need an escalation to a nurse to do an evaluation? We can even have a virtual 5-minute nurse visit, which again, there's a CPT code for that can be done over telehealth by the nurse. And so you can have that. And to make a decision on whether the patient needs to can be seen over telehealth, whether they need to come in, or whether actually they should present to an emergency room or call 911, right? I mean, those are kind of the 4 typical triage scenarios. And so establishing that, because that is very important to the clinicians, is that they only are seeing the right patients and that the process has worked. And that brings us now over to the patient side, right? That's how you set some expectations with the patient, right? If they're saying, yeah, I have some chest pain here, so, right? And I say, well, I see you're like, have you gone to the gym recently? No, I don't go exercise. Right? I got hypertension, hyperlipidemia, obesity, and chest pain. I think, sir, I think you should hang up and call 911 because I think you may be having a heart attack. And so we want to make sure that you are seen as quickly as possible. And I think you should drive yourself to the ER, right? So obviously that's the same as in scheduling for an in-person visit. And then there's some scenarios where some clinicians don't feel comfortable, some clinicians feel comfortable. And again, once clinicians get that seeing a patient over video is always better than no visit or a telephonic visit, then they are also much more comfortable to see the patient. And they might just go afterwards, I cannot really make a good assessment. I think you should get a lab test and an x-ray here, and then I will see you on Friday, and we'll go over that in person. So patient expectation setting is one aspect. And then the other thing that I say about patient enrollment is 2 things. One is the telehealth tech check to make them really powerfully set up with the technology to do that. And then the other thing is just the clinician for a patient who's doing it for the first time to just acknowledge the newness. Just thank them for the effort that they went through. Just acknowledge that they appreciate you being on this video visit. And then the patient will tell, well, thank you, because I didn't have to drive in, I didn't have to do this, right? And then you actually establish this great rapport of everybody being grateful for each other. And that's a wonderful way to start a conversation. So that goes back into that website manners training of the clinicians, just being a little bit more mindful about what the patients had to go through or did not have to go through in order to be there on video.
Do you find pushback with that? Because I know that's been our experience with our FQHCs where there's, we were switching from ACO REACH to MSSP, and we wanted the providers to just a 10-minute thing, acknowledge. Health centers leadership pushed back really hard on that. Our providers don't have time to do that. Our providers don't have time. They have to see patients. They don't have time. So that's a 2-hour training, right? I think you said 120 minutes-ish. And are you getting pushback? If so, if the leadership gets pushback, like what are some strategies?
However, it was 1 hour and 20 minutes. So,
1 hour and 20 minutes. Okay.
And it can be spread over 3 meetings, right? So again, clinicians have regular clinician meetings, and you can have a 20-minute section at 3 subsequent meetings, and then you disseminate the knowledge. So that's based on the anecdote that you shared here of the training. Is like if you don't have the time to learn how to do it right, when you have time to do it over, right? I mean, the old quality adage. So
yes, yeah.
Since the leaders are presumably not measuring the cost of clinicians not knowing how to use that new system, right? So I think it starts with the enrollment of the leadership as well on the change management aspects and making it really obvious and evident what is the cost of non-training, right? So if somebody does it wrong, what is the cost? If you are not doing telehealth well, then the patient will not do telehealth again. But if they cannot come in, then they will not come in at all. And so then you have, right, instead of having 7 visits this year with a patient, you just have 2. And so 5 times your $170 PPS rate, so you just generated a loss of $850 by not asking your clinician to do the training so that they feel comfortable and are well prepared. And that 850 multiplied by 50 patients, that's $40,000. So is this lack of you engaging and enrolling the clinicians worth the $40,000? Again, I'm making the numbers up here, right? So, but this is, and then they can challenge the numbers and say, well, it's not going to be 50 patients, it's going to be 40. Okay. Right. So but you start working on but what is the cost of poor performance? And that's what we need to be present to. It's sometimes, and it's hard to extrapolate from that. So if there's pushback from leadership, then we're in big trouble, because the first starting point really for good telehealth is not the clinicians. The good first starting point is how will telehealth help us to achieve our strategic objectives, which we talked about, I think, at some other point, right? What are the different for geographic expansion, for quality, for physician recruitment, for quality of care, right? So all these different executive strategic objectives and pillars, how can we do that there? So, and it always starts with people don't have the what's in it for me. It's the ADCA model of change management. It's awareness and desire. So first you need to create awareness and desire. And if you have not succeeded, you don't talk about knowledge ability, which is training, right? You have to get those first things. They are sequential. They need to be addressed first. And so you need to win the hearts and the minds first before you can put any new knowledge into the heads.
Yes, absolutely. Very well said. And thank you again for sharing all of your wisdom and taking this time with us. As we just have a couple of minutes left here, but is there one piece of advice that you would leave health center leaders with who want telehealth to be more than a stopgap? What piece of advice might you give?
It is really having a conversation with the clinicians about integrated telehealth. Really seeing telehealth being fully integrated as a viable care modality that actually opens up a whole plethora of options, right? I mentioned that before. You can do, especially in a value-based care environment where we don't have to worry about reimbursement. You can do telephonic check-ins. You can have asynchronous messaging. You can have remote physiological monitoring. You can have store and forward. They take a picture and send it to you, and you'll get back to them within a day or two, right? All these different ways where we can engage patients. When it comes to chronic care management, which is really, right, chronic disease management is one of the biggest challenges that we have here in the US, and a lot of the FQHC population are affected by 2 or more comorbidities, chronic diseases. And so the end in mind is how can we engage and enroll patients more in their care? How can we activate them? Yes. And since we are all human beings, we want to be seen, we want to be heard, we want to have frequent touch points, which our current fee-for-service system does not allow for in the regular basis that we need it or should have it. So for those patients, let's create an environment where we are at their side constantly, where they can reach out with any questions so it doesn't fester into something bigger, more costly, and ultimately more detrimental to their care and with a big impact on their health and their family and their community. And so that is really just really embracing seeing telehealth not as an bolt-on, not as an alternative, not as its own thing. It's just the natural evolution of how we improve access to care and how do we ensure the continuity of care day after day after day, and not just every 6 weeks or 3 months or once a year in the visit. Just educate yourself, have these conversations at the strategic level, and engage your key opinion leaders, your key influencers, your key champions, find your clinical champions for it, and point to good results. And if you want to read up about change management, I highly recommend a 25-year-old book called Switch by Chip and Dan Heath. Got some great stories into switch, how to change when change is hard, great set of stories and anecdotes, uses a little bit different approach, not a three by three step approach, which I also love and have in the back of my mind. But yeah, I just really focus on learning how to be a change agent in your organization.
The only thing that doesn't change is change. Well, thank you so much for your time.
Thank you. I appreciate that. Again, so it's always great. And enjoy how you dive deeper and ask deeper questions. And so, yeah, really hope this was very helpful for those who are listening to these episodes, and hopefully they can take some guidance and some courage away to apply these principles in their own organization.
Thank you for joining us in the exam room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation was as insightful as your last checkup. A big thank you to our guests for sharing their expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. Until next time, take care, and thanks for listening to The Exam Room.